Oh, hey everyone. Thank you. Once again, I'm Glen Zielinski. Thanks for coming. We're going to be talking about the use of saccadometry in clinical practice. Now, saccadometry is a tool that's been used in neurology for several years now. What it allows us to do is quantify saccades, which are, again, fast volitional or reflexogenic eye movements from target to target. It allows us to quantify those at a level of depth and precision that has not been available with other forms of analysis such as VOG. And one of the things that's really fantastic about it is that it gives you the opportunity to very precisely localize specific neurologic lesions within someone's system. And it allows you to do that very quickly. It allows you to do that very precisely. And it allows you to do that in a manner that really lends itself towards being a fabulous rehabilitation tool. Because if you come up with a particular type of therapy that you're questioning whether or not you're having an appropriate consequence on this person's brain, you can quickly run a saccadometry test that takes a grand total of 5 minutes and gain a host of insight in terms of how well their prefrontal cortex is functioning, how all the different mechanisms involved in descending pathways getting from the frontal lobe into the brainstem are working, how well different aspects of the cerebellum are working, and that allows you to tailor your rehabilitation to the demands of the patient in real time. Now, I have been involved in this project for roughly the last year. However, the Saccadometry project was largely started by Daniel DeMine and Sam Gibbs, colleagues of mine in Toronto, Canada. And I don't want to think that I'm taking any credit for the magnificent work that they've done. I came in when the project was pretty much finished, and I'm just helping tweak the final aspects of it. Now, we're using this tool in the interest of trying to generate some new normative data for some projects that I'm not sure to what extent I should be discussing yet, since it hasn't reached publication yet. However, the people involved in this research are, of course, Shelley Massengale from Banner Concussion, and Michelle Petrak, and Daniel and Sam, and, of course, myself. Now, let's start talking about saccades. Saccades, again, are fast visual jumps from target to target. And I'm going to give you a second apology, that being that I'm going to explain every aspect of this pathway on a level that's going to be necessary for people to understand what the technology is used for and how we can engage to make massive clinical changes with it. It's a lot simpler than it actually looks. I'm going to make it simple, then complex, then simple again, and bring it right back to clinical stuff at the end. So let's talk about saccadometry. Saccades provide a great deal of insight about the functionality of critical neurologic circuits. And these are networks that are frequently disrupted in traumatic brain injury and neurodegenerative diseases. And specific patterns of saccadic dysfunction can help diagnose pathology and help you localize the lesion. Saccadometry provides a very rapid means to assess therapeutic efficacy, as I was saying, and it allows for easy monitoring of recovery because, again, these tests take a grand total of 5 minutes to run. Again, saccades are, fast visual jumps from target to target. The shifting gaze from shifting the fovea from one aspect of attention to another aspect. Now, a saccade is a very well stereotyped and well understood mechanism. Saccades show consistent relationships among their size, speed, and duration. The larger a saccade is, the greater its peak velocity and the longer its duration. And even very, very large saccades are extremely fast events. They don't last much longer than about 100 milliseconds, which is the response time of the visual system. And one of the things that means is that when you're observing a patient, if you can actually see their eyes move during a saccade, that saccade is too slow. That right there is already a pathologic saccade. When you are visualizing a patient, you should see an eye movement start in one place and have the eyes essentially disappear and reappear somewhere else. And if it takes longer than that, then you're seeing processing that's longer than your visual system response time. And as a consequence, that saccade is too slow. Now, when we make saccades, we are actually functionally blind during saccadic eye movements. Even though the world seems to be rapidly moving, what happens is that there's no sense of motion, there's no blurred image because of a process called visual blanking. So what essentially happens is that there's neurons called position vestibular pause neurons that are involved in saccades. This is where you integrate eye position with head position, first level of processing, and these are deactivated during saccades, which essentially means that we're functionally blind during the eye movement. Brain uses visual masking and saccadic suppression to cancel the visual motion of the background. Now, once you start a saccade, there's nothing with your visual system that you can do to change the size of the saccade once it's been engaged. Saccades are similar to neurologic action potentials in the sense that they're all or none events. Once you turn on a saccade and the saccade starts moving, if something modifies the phase or the pace or the velocity of that saccade during the movement, that's a pathological event, and we're going to show you what that means shortly. Now, let's start looking at the circuitry involved in generating saccades. Now, it starts with input on the retina. So you have visual input that stimulates your retina. Visual inputs to the system arise from the retinogeniculocortical pathway to the primary visual cortex, and also from the retinotectal pathway to the superficial layers of your superior colliculus. Now, what that essentially means is that your superior colliculus is the primary relay for visual information. Your superior colliculus gets input directly from the retina to help facilitate eye movements, but that input also goes to the thalamus and then to the visual cortex for you to be able to process that. Visual information is processed through several extrastriate visual areas before it stimulates motor structures to move the eyes. Now, from the visual cortex, this is where we start moving forward towards the mechanisms that allow us to generate volitional saccades. The visual cortex stimulates the parietal cortex. It stimulates an area called the lateral intraparietal area, or the LIP, which is in the posterior parietal cortex. And this functions as the interface between sensory and motor processing. Now, the LIP is sort of the site of where you generate your visual map of targets, and it allows you to select targets for which to saccade to in the visual field. It's saccades that are generated by this system tend to be far more reflexogenic. So when you see something rapidly move in your visual environment, you generate very quick saccades that go towards that target. Those are less volitional. Now, the lateral interparietal area projects to both the intermediate layers of the superior colliculus, which is how you generate those reflexogenic saccades, and to the frontal cortical oculomotor areas. And when the frontal cortex is where we start generating the ability to have volitional saccades. There are three relevant areas in the frontal cortex for this. There's the frontal eye fields, which are, for all intent and purpose, the primary moving circuit. There are the supplementary eye fields, which help generate higher order complicated sequences of saccades. And then there's the dorsolateral prefrontal cortex, and the dorsolateral prefrontal cortex is all about response inhibition. So again, the frontal eye fields have a crucial role in executing voluntary saccades. Anytime you move your eyes from target to target on purpose, the frontal eye fields were involved. The supplementary eye field is important for internally guided decision-making and sequencing of saccades. And the dorsolateral prefrontal cortex is involved in executive function. So when people have things like attention deficit disorders or any sort of dysexecutive syndrome, there's usually a dorsolateral prefrontal cortex issue. The dorsolateral prefrontal cortex is also involved in spatial working memory. And it's crucially involved, and this is what we're analyzing with our tests, it's crucially involved in suppressing automatic and reflexive saccadic responses. And I didn't list this, but it's also the area that tends to fire cold on functional MRI when people have chronic depression. Now, all of these frontal regions project to the superior colliculus, and the superior colliculus integrates cortical and subcortical signals. The superior colliculus essentially fires burst generators in the reticular formation, and those burst generators are what ultimately move the eyes. So you can kind of think of the superior colliculus as almost the final common pathway for generating saccades. Superior colliculus is a very important modulating structure, and it helps facilitate or inhibit saccades based on the inputs that it receives from all these other aspects of the system. So the frontal systems, they fire directly to the pontine nuclei in the reticular formation. So you can generate a saccade purely based on frontal output. The frontal systems also fire down to the cerebellum, and the cerebellum is heavily involved in integration of saccades with proprioceptive and vestibular feedback. And these frontal circuits provide the necessary input to the saccadic premotor circuit so that a saccade can either be initiated or suppressed. Now, that, of course, being able to turn a saccade on and turn a saccade off through the frontal system requires another set of modulating circuits. And these are the basal ganglionic circuits. So frontal cortical oculomotor areas, the frontal eye field, the dorsolateral prefrontal, and the supplementary eye fields, they project to the caudate nucleus in the basal ganglia. The caudate nucleus is part of the neostriatum. It's the entryway into the basal ganglionic circuits. And in the big picture, you can think of the basal ganglia mechanism as sort of like the gas pedal and the brake pedal for the frontal lobe. Any motor, or and specifically with respect to saccades, any output that goes through the basal ganglia is either going to be excited or inhibited. So two circuits exist in the basal ganglia. There's the direct and indirect pathways, and these collectively function to excite or inhibit saccadic burst generators. Neurons in the substantia nigra pars reticulata, which we generally just refer to as the nigra, neurons in the nigra form the main output of the basal ganglia circuit by inhibiting the superior colliculus and the thalamus. So if this system is inhibiting the superior colliculus, what the basal ganglia essentially do through these two different pathways is either allow the superior colliculus to be inhibited by the nigra or inhibit the nigra themselves to allow the superior colliculus to fire. Now, some cells in the superior colliculus neurons that inhibit saccadic burst generators, and other superior colliculus neurons fire directly to excite the burst generators themselves. So modulation of these cells through the superior or through the nigra are going to determine if a saccade is initiated or suppressed. And so depending on which circuits are activated within the basal ganglia, frontal output can either lead to saccade generation or saccade inhibition. And both of these pathways are firing continuously and simultaneously to collectively regulate the output of saccadic burst generator neurons in the reticular formation. So that's a complicated way of saying the net effect of all of this circuitry is modulation of saccades. We have pathways that allow us, based on cognitive factors, based on localization factors, based on a host of other factors, pathways that will allow us to turn on or turn off saccades to particular targets. Now, what do these saccades do? These saccades allow us to map the visual world. They allow us to appropriately evaluate and respond to the environment. And failed saccadic modulation can make us react slowly or inappropriately to the visual world. And failure to inhibit reflexive saccades makes the visual world less stable, and it makes us slaves to the visual environment. One thing that we see constantly in people that have had traumatic brain injuries is failed gaze stabilization as a consequence of impairment of a lot of these pathways that we've just described. And when people can't inhibit saccades to targets, this is sort of the essence of most visual vertigo circumstances where people can't reflex or can't shut off reflexive drives to have their eyes hit various targets, which creates a host of problems. Now, in order for your brain to be able to function properly in a visual environment, one of the first things you need to be able to do is inhibit reflexive saccades so that you can have visual fixation. So we have to be able to inhibit reflexive saccades that would move the fovea off the object of interest if we're going to respond to the world appropriately. There's several brain regions involved in this process, including the frontal eye fields, the middle temporal area, the superior colliculus rostral pole, and the vestigial nucleus of the cerebellum. Now, the relevant aspect here is that these systems fire into what are called omnipause neurons. And omnipause neurons sit next to the burst generator neurons in the paramedian pontine reticular formation in the pons, and they suppress saccadic burst generator neurons. Now, the superior colliculus is heavily involved in regulating omnipause activity. There's different aspects of the superior colliculus. It's a very complicated system. I'm going to try to simplify it. You can sort of break it down into two sections. There's the rostral pole of the superior colliculus, and this is involved in fixation on targets. And essentially the rostral fixation zone excites these omnipause neurons that surround the burst cells. And again, the burst cells, excitatory burst neurons, they move the eyes. So superior colliculus, the rostral fixation zone, excites omnipause neurons to inhibit the burst neurons, and as a consequence, we suppress saccades. So if the burst generators are allowed to come to threshold, the eyes are going to move. And the whole purpose of all of these pathways that I've described so far is to determine whether or not that should happen and to modulate that activity to either turn a saccade on or turn a saccade off in response to whatever cognitive stimuli you're trying to respond to. So two pathways through the superior colliculus. One helps drive omnipause neuron inhibition of saccades to suppress reflexive saccades. That's the rostral fixation zone. And then the caudal areas, the lower areas of the superior colliculus, they directly excite the burst neurons to facilitate that saccade generation. Now, omnipause neurons themselves, they're continuously firing to inhibit burst neurons. So these are essentially the brakes for your saccadic system. And generating a saccade largely starts with all that mechanism, all those machinery, all those different pathways that we described thus far. It starts with you taking your foot off the brake, which basically means we need to inhibit omnipause cells to allow the burst neurons to come to threshold. So basically, these Omnipause cells, they pause firing immediately before and during saccades to allow the burst neurons to come to threshold and fire. They're located between the abducens nuclei, next to the cranial nerve 6 nuclei, and they receive input from the contralateral superior colliculus, from the frontal eye field, and from the supplementary eye field. They also receive input from the cerebellum. Now, the mechanisms that move the eyes directly are, again, burst cells. And you can think of burst cells as sort of, you've got a visual grid, and when your brain decides that it wants to move your eyes to a particular target, what it's going to do is yell down into the brainstem and say, I want you to fire 27B/6. And that's going to be a combination of burst cells that code for a particular spot in the visual environment. And again, Omnipause cells are inhibiting all of those burst cells. So what's essentially happening is that that frontal output is going to select those 27B/6 inhibitory cells and shut them off through a combination of superior collicular outputs. And that allows the burst generators to come to threshold. Now, there's vertical burst generators, there's horizontal burst generators. For the purposes of where our saccadometry tool is right now, we're only going to focus today on the horizontal burst generators. Understand that the mechanisms that I describe in the pons for moving the eyes horizontally, similar mechanisms exist in the midbrain for moving the eyes vertically, and it's combinations of horizontal and vertical burst neurons that allow the eyes to reach angular planes, angular targets, places on angular planes in the visual field. So excitatory burst neurons for horizontal movements live in the paramedian pontine reticular formation, in the PPRF. And for those of you that have studied the vestibulo-ocular reflex pathway, the vestibular nuclei first fire the PPRF to drive cranial nerve 6, to drive the abducens nucleus, to start moving the eye in the direction of the PPRF that becomes activated. So left excitatory burst neurons project to the left abducens nucleus, and this moves the eyes left. And then from there, these engage the eyes bilaterally through ascending projections from cranial nerve 6 to the contralateral cranial nerve 3 nuclei through the medial longitudinal fasciculus, and that allows the left eye to move to the left as well. Or, I'm sorry, that allows the right eye to move to the left. So these engage bilaterally, and these excitatory burst neurons project to the pons for what's called pulse step integration, which we'll get to in a moment, as well as to the cerebellum and to the ipsilateral inhibitory burst neurons. So pulse step integration is essentially a critical process that allows conjugate eye motion. Now, eye movements require one frequency of muscle activation to move the eyes. That's called the pulse. And then that needs to be converted to a second frequency of activation called the step that allows the eyes to hold still on a target. Holding your eyes still is an active process because the eyes have got viscoelastic drag from eye muscles, and the eyes are continuously trying to be pulled back into a neutral position just based on drag from these muscles. So anytime you're holding your eyes still anywhere other than in dead center, that requires a frequency of activation of eye muscles, and that's called the step command. So the pulse is a velocity command. It's not a target command, it's a velocity command that moves the eyes rapidly against viscous forces, and that has to be converted to a step command that holds the eyes still once you reach the target against elastic restoring forces. So velocity commands are formulated into position commands by the process called neural integration. Now, neural integrators for horizontal movements are in the nucleus prepositus hypoglossi, the NPH, and the medial vestibular nucleus. And so essentially we consider these things to be the neural integrators. Now, problems with the pulse command result in slow eye movements. If you can't generate an appropriate pulse command, either through descending pathways that go down to drive the burst neurons, or more commonly through problems with the burst neurons themselves, you see slow eye movements that are moving at an inappropriate velocity. Now, problems with the step command, this is what we generally see when people have failed neural integration. Problems with the step command result in failed eccentric gaze holding with slow drifts back to midline or with gaze-evoked nystagmus. So if someone generates a saccade to a target, once they reach that target, their eyes should hold still on that target. And if the eyes have drifts after, if you see glissades, if you see square wave jerks, if you see intrusive saccades, those are circumstances where they've got problems with neural integration. Now, there's also inhibitory burst neurons, and essentially the inhibitory systems are, for all intent and purpose, when you drive an excitatory burst neuron to move the eyes in one direction, that fires an inhibitory burst neuron, and that inhibitory burst neuron fires to suppress all the machinery necessary to move the eyes in the opposite direction. So if you do a saccade to the left, the inhibitory burst neurons shut off all the burst neurons that would do a simultaneous saccade to the right. Now, that's essentially the machinery. I know it's a little complicated. We're going to try to make it a little bit more simple as we move through this. Now, saccade characteristics. The time taken to look at a suddenly presented visual target is known as the saccade latency. Latency is reaction time. Latency is a very good reflection of cortical processing speed. It represents cortical decision time. Cortical decision time is a very useful measure of the general level of cerebral function. And cortical decision time is affected by everything from fatigue to anesthesia to metabolic disorders, and it is almost inevitably impaired in traumatic brain injury, including subconcussive traumatic brain injury. There's lovely research that demonstrates that people that have taken subconcussive head trauma show immediate changes in latency, with latencies becoming longer. Now, saccades to the left and right are independently controlled by each hemisphere. And as a result, they can provide, saccadometry, looking at latency, can provide information about lateral functional asymmetry. So when you start looking at traumatic brain injury and concussion, accurate diagnosis and thus optimal treatment of concussive injuries has historically been hindered by the lack of truly objective tests for the diagnosis of concussion. And although there are current diagnostic tools such as neuropsychological and neurocognitive tests and brain imaging, all these things are important tools, but every one of these things address only some of the neurofunctional or neuroanatomical domains potentially impacted by concussion. And all of the research right now is converging towards looking at aberrancies in eye movements. Aberrant eye movements in saccades and smooth pursuit in nystagmus and invergence have been proven to be informative indicators of brain injury, as have measures of vestibular functions and reaction time performance. There are combinations of mechanisms that you can see dysfunction in these pathways that not only allow you to validate the presence of a traumatic brain injury, but for anybody that does any medical legal work, the literature very clearly demonstrates that aberrancies in these pathways are beyond conscious control, and they're independent of malingering and depression and intellectual ability and so on and so forth. They cannot be faked. Now, if you take a look at a standard reflexive saccade task, the ones that are part of the normal VOG battery that we have in our systems, reflexive saccades are also known as our random saccades. That pathway is basically looking at the stimulus. There's 44 saccades. They jump randomly by 5, 10, 15, 20, 25, or 30 degrees in a horizontal direction with random variation of duration. Now, a lot of people that have seen traumatic brain injuries show normal findings in these saccades, but they show abnormalities in the more challenging tests that we bring out in saccadometry. So for the default saccade test that exists within our system, I mean, here are the parameters. I'm sure everybody's fairly familiar with that. This is someone doing saccade or doing a standard horizontal saccade task. If you look at over here, you can see this is the target moving. This is the latency, the duration between when the target moves and the eye starts to move. That's considered the latency of the saccade. Velocity is the slope of the eye movement. Looking at this graph, this is a terrible velocity, because what we want to see are velocities that look to match, for all intent and purpose, straight lines going up. The faster the velocity, the steeper that slope. And then, of course, there's target position that people hit. And then when you're evaluating a saccade, what you want to look at is, again, this relationship here to here. That's latency. The distance that they reach, that's going to be the accuracy. Normal saccades generally have accuracies between 96 and 100% of the target distance. We look at velocities. We want our saccade velocities to be as fast as possible. And then we look at latency, and latency is, again, reaction time. And then there's a number of other domains that we evaluate, such as saccade stability. This is a patient that has difficulty maintaining gaze stabilization on the target. This is an intrusive saccade that shouldn't be there, and so on and so forth. And the normative data for traditional saccades are pretty well established. When you look at saccade latency, we want anything in this gray shaded area, anything above that is considered to be pathological, which basically means anything above 260 milliseconds for saccade latency is always pathological. But normal is 200 milliseconds and less. The norms for a 20-year-old that's never had a brain injury are less than 200 milliseconds. Now, when we see brain injuries, it's incredibly common that latency is prolonged. We not only see elongated latencies into the 3, 4, 5, sometimes even 600 to 700 millisecond range, but we also see major fatigability of latencies. You can see there's an enormous delta between this patient's good points and this patient's terrible points. And yet that can happen with normal saccade velocity and relatively normal saccade accuracy. So latency is considered to be one of the most sensitive indicators of traumatic brain injury and one of the most reliable indicators of traumatic brain injury incomplete recovery. So when patients have normal accuracy and normal velocity and they still have prolonged latencies, that's a brain that has yet to fully recover from an insult. Now, those are the traditional saccade tests, but saccadometry allows us to drill down very, very precisely and to several deeper levels of what's going on within those pathways. So for saccadometry tests, we use standardized target distances. Essentially what happens with a saccadometry test is that the patient has a target in the middle of the screen, and they're given a choice to saccade to the right or saccade to the left. We rapidly present targets in the same place with random duration on the right or on the left. So saccades alternate between center right and center left. We perform many longer sequences of saccades. For our research, we're doing 100 saccades, 50 per side. The increased number of saccades allows us to have a greater statistical power of the results. Now, saccadometry allows the analysis not only of just latency and velocity and things like that, but allows us to see saccade dynamics over time within the individual saccade as well as within the sequence of saccades. And that allows us to reveal patterns of dysfunction that allow for very precise lesion localization and assessment of pathology. Now, our saccadometry profile consists of two discrete tests. We look at pro-saccades, which are volitional saccades towards a rapidly presented target. And then we look at anti-saccades, which are volitional saccades directed opposite to a rapidly presented target. So pro-saccades, here are the parameters that we're using for our research right now. 100 jumps, 10 degrees, with the mean time interval being 1.5 seconds. We're currently using a 2-dot paradigm. We start with the center and then they move to the target on the right. The jump pattern's randomized. We're using the same colors. We don't give them practice modes. The instructions that we use for pro-saccades are standardized, and it's basically relax, look straight ahead, don't move your head, only move your eyes while tracking the targets on the screen in front of you. Start by looking at the middle dot, then another red dot appears to the right or left, move your eyes to the new dot, and then quickly back to the middle. Accuracy and speed are both important, so do your best to follow the target, and move your eyes as soon as the target jumps, keeping your eyes on the dot until it moves again. Now, during pro-saccade data collection, the provider is going to see the traditional VNG saccade graphs for latency, velocity, and accuracy. However, once this is done, the summary screen shows us several new graphical displays that are key to interpreting the new protocols. So there's basically a patient doing the saccadometry. This is what you see. Essentially, it looks the same as the other task, the other random saccade task, with the one point being that we see standardized intervals, although not durations. Now, once you get through those tests, we have summary graphs that allow us to see much more detail in terms of what's happening with those saccades. So the saccadometry computerized graph shows leftward saccades, which are generated by the right hemisphere. It shows left saccades in red and right saccades in green. So seeing shifts in colors gives you a very rapid way to tell whether or not these mechanisms are functioning appropriately. We're currently only doing horizontals, but soon we'll be doing verticals and angular planes. We're going to have the ability to blow out these graphs individually to drill down even deeper into the data. But currently what we have is a position graph. And so essentially this is where the saccade starts. This is where the saccade ends at 10 degrees. And it shows you position over time. So rather than just seeing a dot, you get to see the acceleration and deceleration of that saccade. You can look at that even more closely with the velocity profile, which allows us to see not only the amplitude and velocity of, or not amplitude, sorry, not only the peak velocity of that saccade, but how long it takes for it to reach that peak velocity, whether or not those peak velocities are consistent, whether or not the time involved is consistent, and what the overall duration of that saccade is. Then we can see latency. Latency is graphed out again over time. It's very easy to see a shift in latency when all of your reds are in one place and all of your greens are in another place. And then one of my personal favorites is seeing velocity over eye position. This allows us to see the phase of the saccade, and the changes in phase of the saccade allow us to see whether or not inappropriate velocity changes took place during that saccade, because they should not. And then finally, we get to look at directional error rate. And directional error rate is key for evaluating anti-saccades, which we'll get to in a moment. Directional error rate essentially means if a target is presented on the right and the patient is asked to saccade to the right during a pro-saccade, a directional error would be them moving their eyes anywhere than to the right. So if there's any initial leftward movement, that would be a directional error. We don't see that very often on pro-saccades, but on anti-saccades, when the task is suppress the reflexive saccade to the illuminated target and move your eyes with a saccade in the equal and opposite direction to the perceived opposite target, directional errors are very, very common. There's some normal level of directional errors. Norms don't exist on what those are yet. In my clinic, we aim for 7% or less. We consider that to be normal. And those directional error rates go up dramatically when people have had brain injuries. Okay, so anti-saccade tasks, it's essentially the same parameters, with the task being when you see a target on the right, move your eyes to the corresponding spot on the left instead. So here's what an anti-saccade looks like in relation to a pro-saccade. So there's, with the pro-saccade, when the target moves to the right, the eyes move to the right. With the anti-saccade, when the target moves to the right, the eyes should move to the left. If the eyes move to the right, that's again a pro-saccade error. All right, now, in an anti-saccade task, there's two discrete mental processes that are required. The first one is the inhibition of triggering a reflexive saccade towards the stimulus. And again, this is a function of the dorsolateral prefrontal cortex. The DLPFC is a critical aspect of brain. It's a critical aspect of executive function. It essentially comes down to what amounts to attentional modulation. And reflex inhibition, response inhibition. So when somebody has a saccade target that pops up on the right, if they're incapable of inhibiting the saccade to the right and generating an anti-saccade to the left, that implies a lesion in the dorsolateral prefrontal cortex. Now, the second aspect of the anti-saccade task is inversion of the visual vector, as in you have to generate an amplitude of the stimulus from one hemifield to the other, and that's a function of the posterior parietal cortex. If you have a pro-saccade target that appears on the left, or your right dorsolateral prefrontal cortex has to inhibit the saccade to the left. It has to talk to the posterior parietal system, which must then talk to the opposite frontal lobe, which must talk to the left frontal lobe until the left frontal eye field to generate a saccade to the right. So clearly there's a lot more brain integration involved in that process. It is assumed that the vector of a visual stimulus is first perceived and inverted in the posterior parietal, contralateral to the stimulus, and then transferred to the posterior parietal, ipsilateral to the stimulus, and then forward to the frontal eye field for planning of the anti-saccade. So the anti-saccade task is a gross estimation of injury or dysfunction of the frontal lobe by assessing the brain's ability to inhibit the reflexive saccade. Because again, all saccadic eye movements are controlled by the frontal cortex. So our anti-saccade instructions are basically relax, look straight ahead, don't move your head, only move your eyes. You will start by looking at the middle dot, then another red dot will appear to the right or the left. This time, move your eyes to the equal and opposite side of the new dot, and then quickly back to the middle. Accuracy and speed are both important, so please do your best to move your eyes quickly to the position the dot would have been if it were on the opposite side. Usually people have no idea what that means for the first task. By the time they get to the second saccade and they've seen both of those, we're also assessing the dorsolateral prefrontal cortex based on visual memory, which is another one of the system, or another one of the aspects of that system. So we have 3 separate anti-saccade options right now programmed into the software. One is this one, where the center dot and the target just flashes, and the idea is that they're supposed to move to the opposite target. That takes the visual memory piece out of the equation. There's another one where they have a center dot and the center dot disappears. This allows us to assess gap stimulus for antisaccades as opposed to overlay. And then there's the classic overlay saccade antisaccade task, which is what we're doing, which is what we're using for our research, where the center dot is maintained and they saccade to the opposite target. When you're looking at an antisaccade graph, we see the same data. So now, that said, when somebody generates a saccade in the wrong direction, when somebody generates a pro-saccade error, we'll see a dotted line in the direction of the pro-saccade error, and then we'll also see that represented in the directional error rate. So this is someone who actually did reasonably well. Their directional error is only 1%. This is a relatively normal brain. Except for a number of factors, one being they have a really big spread on their position. It looks like they're hitting targets anywhere from 10 to about 17 degrees, and they should be very tightly clustered. They're obviously not. As a consequence of them selecting different targets, they've got a fairly big velocity distribution. You can see their phase, they're getting from 10 to 17, so they're sort of all over the place in that. Then you look at their latencies. So this would be a patient that potentially does have some dorsolateral aspects not working that well for visual memory of target selection. But then you can look at their latency. Now again, normal latencies for saccades are 200 milliseconds and less. The normative data doesn't exactly exist that well for antisaccades, but we like to see, based on the best research that we've been able to find, anti-saccade latencies go up by no more than about another 150 milliseconds. We're usually aiming for 100 to 150 milliseconds more than a normal saccade latency. So ideally, we're looking for about 350 milliseconds. And even though this is an allegedly normal patient, there's a pretty big spread on those latencies.
Analysis of the errors and or latencies of the antisaccades can reveal dysfunction in the frontal lobe, and can specifically reveal dysfunction largely in the dorsolateral prefrontal cortex. Now, when a patient's been concussed, there's literature that implies that since the DLPFC is one of the most highly integrated areas of the frontal lobe and indeed of the entire brain, and since concussions involve rotational shearing forces that lead to axonal injuries, and since axons run into the dorsolateral prefrontal cortex for most of the brain, it's almost inevitable that a patient that has persistent post-concussion syndrome has got a dorsolateral prefrontal cortex problem. Now, as a consequence, just about every person suffering from persistent post-concussion syndrome also has chronic and, in many cases, refractory depression. When you look at data on patients that have been concussed, in most cases, we're going to see an increase in pro-saccade latencies above 200 milliseconds, but in some cases, we can see relatively normal pro-saccades, and their pathology is going to show in findings on anti-saccade tasks. So here's a patient that suffered a concussion, and you can see that they have consistently long anti-saccade latencies, but of equal significance is the 53% directional error rate. That means that over 50% of the time, they could not suppress the pro-saccade reflex to move their eyes towards the target. This is a deficit of response inhibition.
Now, when you look at antisaccades, when a patient's been concussed, it's very common that the number of pro-saccades that they generate does not match the number of antisaccades that they're capable of generating because frequently we see significant failure in those pathways. So this can be a circumstance where even though their directional error rate doesn't look that bad, there's just not that many data points. If a patient does 50 saccades and 50 antisaccades in each direction and you only see about 12 to 20 points represented, you can assume that they've got a significant failure in that dorsolateral prefrontal system. Okay, now when we look at saccadometry graphs, there's the position graph. This tells us position over time. This is a distribution of the eye position over time. It tells us where the saccade is at a certain time. And again, when the eyes move to the right, the left side of the brain generates that saccade, and vice versa. Now, if the saccade overshoots or undershoots, that generally means that the cerebellum is involved, and we're going to get to that. It can also mean that there's environmental grids that have been affected in collicular and posterior parietal systems as well. So here is basically a saccadometry graph. You can see how, in this case, these saccades to the left, the red ones, they're undershooting the target. We're aiming for the target being at 10 degrees, and these are generally 8 degrees in the left. They're like 8 to 11. So we can see that even though these latencies are appropriate, and these velocities are maybe a little bit slow. They're fairly accurate going to the right, but they're hypometric going to the left. Now, there's also velocity over time. This allows us to see how fast the saccades are going with acceleration up and acceleration down. And again, these should be at the same speed if your oculomotor plant and the mechanisms involved are working appropriately. So the speed of a saccade is highly related to the health of areas in the brainstem commonly affected in neurologic disorders. Velocity of a saccade is largely about burst neurons. Here's a patient that's normal. Here's a patient that's concussed. This concussed patient is only hitting about 200 degrees per second at peak velocities. We like to see 350 plus. Now, there's latency. We've discussed latency. When you look at their latencies, again, that's reaction time. Reaction time tends to suffer in a host of neurodegenerative disorders, and reaction time is almost always impacted in traumatic brain injury. So people that have been concussed or suffer from neurodegenerative disorders such as Alzheimer's and Parkinson's have got pathologically long saccadic latency times that are greater than 200 milliseconds. And it's not uncommon to see this in like the 400 to 600 millisecond range. Here's a patient where you can see their jumps in green. Their jumps to the right have got much shorter latencies than their jumps to the left. That's a fairly significantly impaired brain, despite the fact that their position and velocities are fairly consistent among each other. Now, there's phase. Phase is one of my favorites. Phase is eye velocity at eye position. And the phase graph shows us how fast the eyes are moving at each eye position. So when a normal phase graph should just look like this. It should just be a curve. And ideally, the red ones and green ones overlap. Ideally, they look the same. We should see a smooth curve. We should see no disruption in that movement. Now, when you see changes, when you see bimodal phase plots, ones that look like these M's, where the saccade speeds up and then suddenly slows down in the middle and then speeds up again to reach the target, this is always pathological. Bimodal phase plots indicate that saccades slowed down mid-flight. Now, again, saccades are all or none events. A saccade should just launch, and it should speed up, and then it should slow down, and it should hit the target. Step frequencies encode a unique velocity and do not allow the saccade to slow down. So when a saccade slows down mid-flight, that usually implies aberrancies in activation of Omnipause cells. So again, Omnipause neurons inhibit burst neurons, and the process of generating a saccade largely starts with shutting off Omnipause cells to allow the burst cells to come to threshold to move the eyes. Now, frontal pathways, frontal basal ganglionic output, pathways through the frontostriatal system come down through the collicular mechanisms to inhibit those Omnipause neurons to allow the burst cells to come to threshold and move. If those descending mechanisms from the frontal lobe and through the basal ganglia and the superior colliculus are not healthy enough, frequently what we see is that they function sufficiently to engage the saccade, but they're not healthy enough to keep the Omnipause cells shut off throughout the duration of the saccade, which means the saccade starts, the Omnipause cells come to threshold during the movement, and they intrude on the saccade and slow it down, requiring the generation of another pulse command to speed the eyes back up. So when we see those bimodal things, that almost inevitably implies frontal basal ganglia pathology of some kind. So phase is, again, eye velocity at eye position, and you can clearly see that there's a difference between right and left in this target. Now, that's basically the machinery. Now we're going to start talking about how you can use this clinically to assess lesion localization and in rehab. So to generate a leftward saccade, the right frontal lobe is going to say, I want to move the eyes to the left 20 degrees arbitrarily. So I'm going to generate a signal of, say, 350 degrees per second. I'm going to generate a pulse that says move the eyes to the right 350 degrees a second. So it relays that signal through the basal ganglia and through the superior colliculus to the burst neurons in the right pons, as well as stimulating those directly. So descending pathways run down to hit the burst neurons in the PPRF. These burst neurons excite cranial nerve 6. They excite the abducens nucleus right here. which moves the eyes to the left, which moves the left eye to the left, and then it fires back up through the medial longitudinal fasciculus to get to cranial nerve 3 to move the right eye to the left. And again, this is also the VOR pathway, and this is also the pursuit pathway, and this is essentially the oculomotor plan is what's necessary for you to move your eyes to the right or left using the same machinery. The only difference is what are the inputs to that machinery. So left excitatory burst neurons stimulate the right cranial, or I'm sorry, left excitatory, there's a typo right there. Anyway, when we activate the PPRF, we cause the eyes to move binocularly in the direction. Now, the reaction time of a volitional saccade is known as the latency. The latency represents prefrontal cortical processing speed. Normal latencies are 200 milliseconds and less in healthy individuals. There is some variation on the theme. Latencies go up a little bit with age. Latencies above 260 milliseconds are always pathological. Now, increased latencies in one direction generally represent problems in the opposite frontal lobe. So if I have increased latencies of rightward saccades, that's a left prefrontal cortex problem. Now, burst neurons in the brainstem, the burst neurons on the right inhibit the burst neurons on the left. And these burst neurons are always oscillating. The right ones are inhibiting the left ones, which inhibit the right ones, and back and forth and back and forth and back and forth. If burst neurons are left to their own devices, if they're unregulated, your eyes will never be still, because burst neurons not only respond to saccadic commands, they also indirectly result in changes in luminance, visual motion, sound, and so on and so forth. There's a host of different things that will cause burst neurons indirectly to come to threshold. So they need to be inhibited at all times. They need to be regulated and modulated. Now, failure to generate an appropriate pulse command can lead to slow saccades, and slow saccades generally represent pathology in the ipsilateral burst neurons. If we see dysfunction, if we see a slow saccade to the right, that usually means that the right PPRF has got some level of dysfunction. Now again, Omnipause neurons tonically inhibit the burst neurons, and that allows for stationary gaze. So in order for a saccade to take place, Omnipause inhibition has to be deactivated so that burst neurons can come to threshold and move the eyes. And as the brain fires down with a pulse command, it also inhibits Omnipause cells associated with the desired burst neurons. Now, saccades that slow down mid-flight are the result of Omnipause neurons coming to the threshold, which basically means the brain and basal ganglia may be functioning well enough to turn off an Omnipause neuron to initiate the saccade, but not well enough to keep it off during the entire movement. Now, the Omnipause neuron intrudes on the saccade, and it slows before it reaches the target. This creates that bimodal phase plot on Saccadometry. Omnipause intrusions are frequently seen in disruption of frontostriatal circuits in traumatic brain injury. They're also seen in neurodegenerative diseases affecting the basal ganglia, such as in Parkinson's disease. Now, again, Omnipause neurons inhibit spontaneous burst activity between saccades, and when gaze stabilization between saccades fail, burst neurons come to threshold and they produce square wave jerks or intrusive saccades. So when you saccade to a target and then you have extra saccades coming off the target or small square waves, this is again a function of Omnipause neuronal failure. Pause activity is driven by inputs from the vestigial nucleus of the cerebellum, from the rostral superior colliculi, and from the frontal eye fields. And this is very useful because neurologic examination through your physical exam can reveal findings associated with the pons, with the cerebellum, with the midbrain, with the frontal lobe, and allow you to localize where that gaze stabilization failure is being generated from. In our world, it's not enough to be able to say that somebody has failed gaze stabilization and start doing gaze stabilization exercises. We generate our results based on taking the fact that a patient has gaze stabilization failure, coupling that with a solid neurologic exam, and being able to say this is coming from the left prefrontal cortex, and then we will engage left prefrontal cortex exercises in concert with gaze stabilization exercises in the interests of facilitating a much faster and much more effective change. Now, neural integrator lesions result in failure to convert a velocity to a position command. So neural integrator lesions generally create gaze-evoked nystagmus. Somebody does a saccade to a target, they hit the target, they hold on the target briefly, and then their eyes start drifting back towards the midline with a fast phase back to the target. Now, if a saccade is accurate, but the eyes cannot subsequently be held on the target, this is generally a failure of neural integrator and the Omnipause cells. You can see gaze-evoked nystagmus. You can also see things like glissades, little slow drifts coming off the target, so on and so forth. Now, saccade accuracy, this is important. We haven't spoken about this yet. Saccade accuracy is largely a function of the cerebellum on the side to which the saccade is directed. So when you do a saccade to the left, it's initiated by the right frontal lobe. The only thing that's fast enough to stop a saccade is actually a saccade in the other direction. Omnipause neurons don't stop saccades. If I'm doing a saccade to the left, I have to initiate an equal and opposite saccade to the right to make the eyes stop. So as the eyes move to the left cerebellar fastigial nucleus, the left cerebellum, is involved in saccade generation to the right. It's going to fire right burst neurons. And at the precise moment the eyes reach the target, the left fastigial nucleus in the cerebellum fires right burst neurons to initiate an equal and opposite saccade to stop the eyes on that target. And as soon as the eyes stop, at that instant, omnipause cells activate to inhibit further movement. So basically, here's the cerebellum, the fastigial nuclei, the caudal fastigial nucleus. It's going to fire to drive PPRF cells. So we've got the right one driving PPRF burst cells on the left, creating an opportunity for us to generate that equal and opposite saccade. So what does that mean? If you have a lesion in the fastigial cerebellum, you're going to have hypermetric saccades. They're going to overshoot. Saccade undershoot is considered normal to an extent. Saccade overshoot is always pathological. There's no normal range for overshoot. So the fastigial nucleus on the side the saccade is moving towards fails to fire appropriately. The opposite saccade is not generated on time, and the eyes overshoot the target. Saccadic hypermetria is the result of ablative lesions of the cerebellar fastigium in most cases. Now over here, there's also the dorsal vermis. It's also known as the dorsal oculomotor vermis. We're talking about another section of the cerebellum. What the dorsal vermis does is fire down to inhibit the fastigial nuclear complex. So the dorsal vermis of the cerebellum inhibits the deep cerebellar nuclei, including the fastigial nucleus. Now, if the dorsal vermis fails to inhibit the fastigial nucleus comes to threshold too quickly, it stops the saccade too soon, and the saccade undershoots the target. So dorsal vermal lesions lead to saccade undershoot. They lead to saccadic hypometria. And generally, you're going to see not only saccades that stop short, but you'll see multi-step saccades as the patient realizes they're not on the target and they generate extra steps to reach the target. So here's the clinical summary and all that stuff. Saccade latency is a function of the frontal lobe opposite the direction of the saccade. Saccade accuracy is a function of the cerebellum in the direction of the saccade. Saccade overshoot is a function of the cerebellar fastigial nucleus, failure. Saccade undershoot is a function of the cerebellar dorsal vermis, failure. And saccade velocity is a function of ipsilateral burst neurons. If they're slow, the burst neurons aren't functioning well enough. And then finally, stability after a saccade is a function of ipsilateral neural integrators for slow drifts and omnipause neurons for quick phases. All right, that's a lot. Now let's talk about antisaccades. Antisaccades, frontal eye fields have a crucial role in executing voluntary saccades, but the dorsolateral prefrontal cortex is involved in executive function, spatial working memory, and suppressing automatic reflexive responses, as in antisaccades. Now, antisaccades are much harder to do than pro-saccades. Antisaccades are more metabolically demanding than pro-saccades in the frontal eye field, the supplementary eye field, and the dorsolateral prefrontal cortex. Antisaccades are implicated in a host of neuropsychiatric conditions, including bipolar disorder, schizophrenia, Tourette's disorder, ADHD, bipolar, personality disorders, and so on and so forth. This is considered to be a bedside test for a patient that's dealing with executive function disorders. Poor antisaccade performance is also seen almost inevitably in traumatic brain injury and in neurodegenerative disorders. It takes a great deal of brain output to suppress the reflexive drive to generate a pro-saccade. And again, the DLPFC is involved in response inhibition, and it's the primary region involved in antisaccade generation, along with inputs from the frontal eye field and the supplementary eye field. The DLPFC provides top-down inhibition to the frontal eye field and superior colliculus to inhibit automatic pro-saccades. And again, the DLPFC is the primary target for excitation when somebody's got chronic depression because it fires low. So patients with discrete lesions of the DLPFC are going to have difficulty suppressing the pro-saccade. We see increased directional error. And again, most and potentially all patients with persistent post-concussion syndrome have lesions of the dorsolateral prefrontal cortex. In lesions of the frontal eye field, the ability to suppress the pro-saccade is intact, but the ability to generate the voluntary anti-saccade is impaired. And then in Tourette's patients, there's no increase in the directional error rate, but they show increased latencies on both their pro-saccades and on their anti-saccades. Okay, now let's look at some cases. This is how we're going to tie this up. These are a bunch of patients that I've seen over the last month. This first one is a patient that had a vertebral artery dissection. Somehow she survived. Classic Wallenberg presentation. It led to a fastigial cerebellar injury and profound saccadic hypermetria. So you can see over here her latencies to the left, not too bad, 220, that's not bad for a 68-year-old woman. 305 to the right, that's not good enough. So right there we're talking about she's got a left prefrontal cortex problem resulting in those long latencies. We look at her velocities, they're reasonable. We look at her accuracy, and again, overshoot is never normal. Overshoot is always pathological. And when she does saccades to the right, she's overshooting by 10%. When she does saccades to the left, she's overshooting by 20. So again, her saccades to the left massively overshoot. Her saccades to the right, some of them are okay, some of them are a little bit overshooting. All of them are going inappropriately to the left. And her gaze isn't stable. She's got square wave jerks. She has intrusive saccades. Now, this is her pro-saccade data. And again, you can see on this particular task in my office, I was doing 20-degree jumps. So all of her targets should be stopping here. We should never see any overshoot, and you can see that she's hitting as high as like 27, 28 degrees in some cases. We look at her velocities. You can see some bimodal distributions there. You can see them better here on those phase plots. So she definitely has some Omnipause activity that's inappropriate. With her saccades to the right, that's from that left prefrontal cortex lesion, and it's affected her left basal ganglia. We can see that her latencies are higher going in one direction than in the other direction. But when we look at her after 1 week of therapy, and essentially what we did was not saccade exercises, but fastigial cerebellar exercises. I saw her a few times a day for a week. At the end of the week, her saccade accuracy to the right was normal. Her saccade accuracy to the left had improved by 50%. And why is this relevant? The difference between the beginning of the week and the end of the week is that at the beginning of the week she was wheelchair bound, and at the end of the week she was walking. She had her balance back. These were her anti-saccades, and you can see, or I'm sorry, this is her pro-saccades, and you can see that they've improved significantly in terms of the accuracy. Now, this is another TBI patient that I had 2 weeks ago. Despite a host of post-concussive complaints, his primary issue was severe chronic depression post-mTBI. If you look at his saccades, they're relatively fast. His velocities are actually quite good. They're reasonably accurate. He's in the 90s. We like to see these numbers between 96 and 100, but that's not that bad. It's fairly normal. You look at his latencies. He's got the capacity to generate some normal latencies, but he's got a pretty big latency distribution, and it averages out to 249 right, 236 left. That's a little high for somebody that's in his early 30s. We look at his pro-saccades. We can quickly see that he's got a little bit of Omnipause activity given those bimodal distributions. We can quickly see that his latency is dramatically different from one direction to the other direction. You look at his directional error rate with pro-saccades, it's essentially fine. And you can see that his velocities quickly are very, very high. But then we look at his anti-saccades. Now, on the standard saccadometry graph, we can see a huge difference in his latencies. These latencies should be the same. And like I said, we like seeing latencies go up by 100 to 150 milliseconds when you do an anti-saccade task. And he did that just fine going to the right. But his latencies going to the left went up dramatically, 538 average millisecond latency, which is far too high. But more importantly, when we look at his anti-saccade directional error rate, we can see that despite having 0 pro-saccade errors, 4 in 10 go in the wrong direction. And he also suppressed a ton of those. A ton of those didn't even register on the graph. You can see that there's far less data here. So he didn't even generate the majority of his anti-saccades, or they were so slow that the computer considered them to be the next saccade and they rejected it. So you can see a dramatic change in his latencies. Now, again, dorsolateral prefrontal cortex is the primary target for chronic depression. We do a lot of transcranial magnetic stimulation in my office. We've got a couple of TMS units, and we took TMS, coupled that with specific saccade and predominantly anti-saccade rehab. And after 2 days of therapy, his latencies were improved. His velocities were still great. We saw a significant improvement in his anti-saccade latencies going to the left. But more importantly, he had 0% directional error, and that was after, I think, 4 treatments over 2 days. And at the end of that period, he was describing feeling better than he had in 25 years. All of his affective issues had resolved completely. We did a follow-up on him a few weeks later, and he was still fine. Here's another case. This is a patient that has early Parkinsonism. They haven't been fully diagnosed with Parkinson's disease, despite the fact that they had a pill-rolling tremor that had just degenerated. I was sort of the first person that said, you have Parkinson's. Subsequently, other providers have validated through DAT scans that, yes, she does. We can see that she has a lot of intrusive saccades. Eyes are moving when they shouldn't. Her accuracy going to the left isn't that great. Her velocity is slow. She's got some significant latency distributions. But the thing that's relevant here is, again, we were talking about omnipause intrusions, how when the saccades, when the basal ganglionic mechanisms are not healthy enough to keep the omnipause cells off throughout the duration of the movement, we see a change in phase, and we see these bimodal distributions where the saccades speed up, then slow down, then speed up again as they approach the target. And that's her, and she obviously has this happening in both directions. Okay. We looked at her antisaccades. Despite the fact that her saccades were relatively normal, her antisaccades were pretty dramatically high in terms of their latencies. That's far too high, and you can see that her velocities were very low with her antisaccades as well. And again, we had some pretty significant directional error rates, and you can see that on her antisaccades, the bimodal distribution stuff is very glaring. Her system she also had a fairly significant neural integrator lesion, and when we looked at this on normal saccade tests, you could see that she'd have some saccades that would be fine, and in other ones she'd have a combination of omnipause intrusions and glissades, all these slow drifts coming off the target. Okay, here's my last case, I believe. This is a patient that had a TBI, and she'd gone through a host of TBI rehab at a number of different centers. She still kept describing how she was not herself. She had a bunch of neurocognitive tests that had some inconclusive results. This was a medical legal case. She was asking me to validate whether she did or did not actually have a brain injury, and it was very obvious that she did. And the thing that stuck out more than anything was that these are her pro-saccades, and as she's doing these tasks, they initially look pretty good, and she's got a fairly tight latency cluster. However, as the cortical processes, as her executive function pathways start to fail, she starts losing the task, and her latencies get longer and longer and longer, and the farther into the test she was, the worse her latencies were. And then we looked at her anti-saccades, and she had extremely high latencies, and she barely generated any data. So the higher the executive function task, the more we were able to represent that objectively as being dysfunctional as a consequence of this. All right, so that's basically where we're at with the saccadometry right now. We're going to integrate angular saccades, so the ability to generate targets not just on horizontal planes but also on vertical and angular planes. We're going to have that into the software in future revisions. We're going to have the ability to blow out individual graphs and drill down into the individual saccades a little bit more precisely and see where they are in the sequence. And then we've also got some other stuff coming out. We're going to be testing self-paced saccades, memory saccades, and reaction time using pressing buttons on keyboards. So self-paced saccades, this shows us a lot of other stuff. Do as many saccades as possible. Memory saccade guided sequences and reaction time. We're going to be looking at some pilot studies for that for Visualize beginning in early 2020. So in summary, different patterns of saccadic dysfunction correspond to different areas of brain involvement. And when saccades are not functioning as well as they should, according to the stereotype standards, we can extrapolate where the client's brain may be underperforming. And in general, latency issues, sluggish responses usually indicate there's a frontal lobe issue. Accuracy, that's usually a problem with cerebellar integration with the brainstem. And then velocity issues are usually about the brainstem itself, about burst neurons. I'm more than happy to be responsive to any questions anybody might have. So feel free to contact the Academy, and anything will get to me, and I'll be happy to answer.